Afternoon, everyone. Thank you so much for joining us today at Transcendent's Community Concussion Talk. My name is Nick Reed, and I am the lead for knowledge translation and community engagement for Transcendent. And as part of my role, I have the great pleasure of hosting today's session. Our community concussion talks are designed to engage the community on critical topics related to concussion, creating a space to share knowledge, insights, and lived experiences. We intentionally pair experts in the field of concussion, both clinicians and researchers, with those who have lived experience with concussion and their insights to provide a rich description of these important topics. We are very fortunate to welcome our presenters and attendees today from across Canada and beyond, and I want to thank you for carving time to be with us today. Today we have speakers from both the University of Toronto and the University of Ottawa. And I will acknowledge the land which I sit on here at the University of Toronto before we begin today's presentations. We would like to acknowledge this land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work and learn on this land. Thank you. So we're in for a real treat today. We have 4 fantastic presentations planned. What I will do, just for some housekeeping, is I'll read the bios of each of our presenters in advance of their individual talks. Also, a reminder to all attendees in our Zoom room today to add your questions for our speakers into the chat, and we'll have time to answer them after all of the presentations are complete. So without further ado, I am very pleased to introduce our initial speaker for today's session. That is Dr. Roger Zemek. Dr. Roger Zemek is an emergency physician at the Children's Hospital of Eastern Ontario and a senior scientist at the CHEO Research Institute. Dr. Zemek leads the TRANSCENDENT Concussion Research Program, where the goal is to identify markers that can be used to track concussion recovery across all ages and types of injury, and use new and emerging technologies to improve the diagnosis and advance the treatment of patients with concussion. Dr. Zemek previously led the largest pediatric concussion study to date, examining the predictors for persistent post-concussion symptoms in children. He has also led studies to optimize return to physical activity, return to school, and screen time after concussion. He leads the International Living Guideline for Pediatric Concussion that provides up-to-date best evidence recommendations for healthcare professionals, patients, families, teachers, and coaches. All that said, Roger is a leader in our field, a mentor of mine, and a friend to many of us. So I will now pass the virtual mic over to Roger for his presentation. Over to you, Roger.
Thank you so much for the warm introduction, and I'm really excited to talk to everyone today. What we're going to be talking about today is the brain-heart interconnectome in concussion. I'm just starting from my slides. So I want everyone to, before we get started, I want everyone to just close their eyes for a moment. Picture this. You're 18 years old. You're off at your first year of university, living away from home for the first time. The biggest worry in your life are your upcoming midterms. Open your eyes. Meet Maya. Maya's 18. She's a first year university student, but 5 days ago, her world was turned upside down. She was walking back to her dorm, slipped on the ice, and fell down, striking her head against the sidewalk. She didn't lose consciousness, but immediately had a pounding headache. She was dizzy, and her friends said she was wobbly as she tried to get her back up and start walking again. That was 5 days ago. And now today, Maya's still having a headache. She's still dizzy when she stands up. The bright lights of her laptop are feeling like a spotlight in her eyes. And the doors closing, people laughing, the normal sounds of her dorm have become overwhelming. She's really worried. 2 years ago, she had a concussion, and it took months to get back to herself. Now with her midterms looming, all she's thinking is, I can't fall behind. I can't go through this again. Maya's story isn't unique. Hundreds of thousands of people face this exact same situation every year in Canada. And it's what brings us to our purpose of today's talk. Are there ways in which we can get Maya feeling as better, as quickly and as safely as possible to get back to her life? So to start, let's just review briefly what is a concussion. A concussion is caused by a blow, either directly to the head or indirectly, that leads to a shaking of the brain inside. It's an injury that can occur from all different settings: motor vehicle collisions, falls like Maya had, sports, even assaults. What happens is the cells of the brain are injured, which means it's a functional injury, not a structural one. On that cellular level, there's changes to the neuron membrane, there's changes to how neurotransmitters are released, the cellular metabolism can be disrupted, and even the blood flow to the brain can be changed. And that's why concussion can't really show up on a picture, because those things often are not shown up on structural routine pictures. And I know Dr. Connelly will be talking about some more advanced research pictures later, but it's really sometimes confusing for patients when they go perhaps get a picture after an injury and be told it's normal. It's really a software problem, not a hardware problem. And that's probably the best way to describe it to my patients. For years, the standard treatment for concussion was people were told to go home, stay in a dark room, don't go to work, don't exercise, rest. Wait till your symptoms are gone. But we now know that that practice, known as cocooning, doesn't just fail to help, but it can actually cause harm. So to understand why, we need to go rewind the clock about 10,000 years. So now imagine you're one of our ancestors. You're walking through the savannah. Suddenly, from behind a thicket of grass, pops a lion. Your body's ancient hardwiring kicks in. Your body is telling you danger. It's your fight or flight response, and it's controlled by our autonomic nervous system. When you see that lion, suddenly your brain switches to what's called the sympathetic state. Your pupils dilate to let in more light as possible. Your heart rate skyrockets, pumping blood primarily to your muscles. Your brain's filters are all turned off, so you can hear every rustling leaf or snapping twig, because that could be the lion's brother. Your anxiety levels skyrocket in order to make sure your brain addresses the danger signal that it's sending. It's brilliant for survival. It primes your body to either fight or run away. Now, that's really helpful 10,000 years ago, but not so helpful for Maya here in 2026. Her concussion symptoms are also resulting in her autonomic nervous system to be in disarray. Her danger is going off, even though there's not a real lion. She's sensitive to the light because her pupils are still bigger than they need to be. Loud noises are overwhelming, and the normal sounds of the dining hall are more disruptive than they should be. Why is she having headache and dizziness? Well, it's very possible the disruption of the cerebral blood flow, primarily sending to her muscles rather than her brain. And why is she having trouble sleeping and having so much worries? Her body's in a constant state of high alert. It's hard to sleep when you're worried about a danger. So for decades, we told people to rest, not to exercise. We were giving the exact opposite advice of what our body's ancient wisdom told us to do when it experienced this danger. So our understanding of concussion led to a fundamental paradigm shift less than 10 years ago in how we now treat concussions. We challenged the dogma in which we told people said, rather than just rest, what if we use our body's response to actually move? The overall synopsis of all this evidence is this: early exercise that can be tailored to individuals can help reset the autonomic nervous system and get people back to their lives. Now, you may be thinking, exercise for concussion? Isn't that dangerous? Well, it potentially can exacerbate symptoms, and that's why we say the right dose of exercise. And what you're seeing here in this picture is what's called the Buffalo Concussion Test, in which people's individual Goldilocks zone of exercise is determined enough to get the benefit, but not too much to exacerbate symptoms beyond mild. And we also aren't just saying any exercise. We certainly don't want people going back to dangerous activities. Like we wouldn't want a football player, a rugby player, or a hockey player returning to a competition the next day. We want that exact right dose for that right person. Now, how does exercise potentially benefit concussion and the autonomic nervous system dysregulation? Well, that's one of the steps, is resetting the autonomic nervous system. It's the core element of resetting that thermostat. It restores the flow state between the parasympathetic and sympathetic states. Second, It helps to renormalize the blood-brain flow. Exercise can help the brain regulate its supply more effectively and reduce some of the symptoms such as headache or even dizziness. Third, with exercise, your body releases a protein called brain-derived neurotrophic factor, BDNF for short. Think of it as fertilizer for the brain. It basically helps the brain repair itself and heal itself, what we call neuroplasticity. Third, psychological stress and depression often accompany concussion, and our team has demonstrated this in multiple studies. Physical activity is a powerful non-pharmacological tool to help reduce emotional distress and improve mental well-being. Third, a lot of patients complain of, or fifth, a lot of patients complain of cognitive concerns after concussion. Prescribed exercise has been shown to improve mental clarity, cognitive function, and learning, helping to reduce some of the fog that accompanies concussion. And finally, exercise can help tackle and restore some of the problems that often occur after concussion, namely sleep. Sleep quality and duration are absolutely critical for brain recovery. Finally, it's a low-cost intervention that can be implemented by anyone, anywhere. So let's get back to Maya. In that old story, she'd spend weeks or months in that room, falling behind, worsening anxiety, her world shrinking, more social isolation, more symptoms. But in this new paradigm, her future is different. She's now, the day after assessment, back to moving. She's on a stationary bike in the university gym. She's exercising within her heart rate zone. Within a few days, her headaches start to lessen. Her dizziness is starting to reduce. She's tolerating lights. She can go back to the classes, and she's catching up on her studies and hanging out with her friends. By working with the body's ancient wisdom rather than against it, we're moving away from passive rest to active treatment. So one of the key take-homes that ties in the brain-heart interconnectome is that early treatment concussion needs to include early physical activity tailored for individuals' needs. This tailoring to individual needs and getting people back to life is really the North Star of our program of research, which I just briefly wanted to introduce beyond this story of Maya. We talked a lot about exercise and its evidence after concussion, but there's still so much we need to understand about concussion, what causes its symptoms, how to get people back to work, life, and doing the things they love to do. As part of better understanding what the needs of our patients are, our team interviewed over 1,000 people across Canada with lived experience of concussion, as well as their caregivers, and as well as hundreds of frontline healthcare providers who treat concussion regularly to determine what are the shared top 10 priorities for concussion. I won't read them all out loud, but if you're curious, you can scan the QR code and get the output of the top 10 priorities, which really is a North Star and drives our research. That whole priority has become what we call the Transcendent Concussion Research Program. We are enrolling with a goal of 6,000 people across the 360 concussion care clinics, people of the entire age of injury, from toddlers to seniors, across all mechanisms, of which we are doing a structured, comprehensive, deep dive into the understanding of how we can better understand what symptoms are having, what drives their symptoms, what are earlier ways to intervene to get people back doing better, and also importantly, ways to prevent a future re-injury. If you're curious about all the things that we are evaluating, I put another QR code that explains our full protocol. But I just want to highlight some high-level novel things we're doing. Some of those things include the autonomic dysfunction sub-study, which we'll be talking more about today, and Dr. Sicard will be sharing some of the early results from that study. Things that we won't be talking about today due to time, we are collecting interesting fluid biomarkers such as saliva and blood to determine if there's any proteins or changes in what we call microRNA to better predict recovery and or to tailor treatment and monitor whether someone is recovered or not. We have a whole program looking at the visual vestibular elements of concussion, and we have what's called one of the only eye trackers in Canada. It's called the Oculogica eye box and people follow a little movie around the screen and it tells us how well their eyes are moving together, if there's any problems in which their eyes are not working properly. We are doing tests in people who are non-athletes, for example, concussion bike tests. And lastly, we're sending some people to do additional studies on research scanners, and Dr. Connelly will be talking about some of the work that he is doing with his team on advanced research scanners as well. Finally, we also are now able to monitor better people outside of the clinic using our wearable stub study, which also started. So really today's talk is to focus on the autonomic dysregulation. And for that, these are the elements of the protocol that we'll be focusing on today. Why is that important? Well, if we understand autonomic dysregulation, we can answer just in that alone at least more than half of the priority questions that people identified, namely, can we better predict who's going to recover better? Who needs certain ideal combined medical or physical treatments? How can we prevent mental health outcomes? How do we get people back to returning physical activities? Management of headaches, and of course, getting people back to sleep. So I am, as Nick said, it was a privilege to introduce. It is a privilege to be able to present as well. I am one person of a huge, massive team of over 30 internationally respected, world-leading scientists in this field. But more importantly, we've got an amazing community advisory team, and we're so happy to have Roanne with us here today as well to talk about how this is an important element of how we shape our research. We've already enrolled over 2,700 people in this study. Without their willingness to be part of it, we'd have no discoveries to share. And then finally, this work would not happen with the research support and administrative and operational support of the Ontario Brain Institute, the Brain-Heart Interconnectome CREF funding, as well as the CHEO Research Institute and 360 concussion care teams. So I'm excited to learn more myself about the rest of the talks today. So I look forward to passing it back to Nick to introduce our next speakers. Thank you.
Thank you so much, Roger. Fantastic presentation, and really appreciate you acknowledging all of the important people that make this work possible. It is a team sport here, and we appreciate your leadership in all of it. So much appreciated. Roger set up this segue perfectly. We'll now be hearing from Dr. Roanne Segal. I will share Roanne's bio, and really looking forward to hearing from Roanne today. Dr. Segal is a retired physician and associate professor of medicine at the University of Ottawa, with a clinical and research focus in oncology rehabilitation and survivorship. Today, Roanne joins us in a role as a community advisory committee member for our Transcendent Concussion Research Program. After sustaining a concussion in a biking accident several years ago, she brings both her clinical expertise and lived experience to this conversation. She is passionate about bridging patient and clinician perspectives and advancing research that meaningfully supports individuals and families affected by concussion. Roanne, we are so grateful for all of your contributions to our Transcendent program and for being here today. I will pass the virtual mic over to you now. Thank you.
Thank you very much for that lovely introduction. I'm bringing really my experience from the other side of the white coat. For the first time, I found myself being the patient instead of the healthcare provider. And let me tell you, it was a fascinating and interesting experience. And I hope to be able to share that with you and bring some of my insights and perspectives to the table. So my story, probably similar to many of you on the call today, started on a quiet Sunday morning. My husband and I went out for our usual long bike ride. We live in the country, so these are quiet country roads around a beautiful lake. I was in my happy place, not concentrating because I was just riding, and a truck just backed out from the driveway into our pathway. My husband slammed on the brakes. I was drafting, which means I was really sitting on the back wheel. I smashed into him and went head down on my left side, landing hard enough on the pavement that I actually smashed my helmet. I was able to stand up and I rode home because he asked me to go get the car to come back because his bike was completely totaled in the accident. I have no memory of what follows, so I'm telling you what people have told me. Later that night, the headaches, the nausea, and the vomiting started. I really resisted going to the hospital, but after a little bit of persuasion, even I had to acquiesce, and we spent many an hours waiting for that inevitable evaluation and to get the CT scan. And it has been pointed out, we wanted to make sure it was negative, nothing else was going on. What followed for me was 2 weeks of hell. I couldn't eat, I couldn't sleep, I couldn't move. The headaches were just so unimaginable. I really did not know what to do with myself. This is not my area of expertise in any way, shape, or form, and I really had nowhere to go, and I didn't even know who to call. Eventually, I did reach out to my family physician, who referred me to the Transcendent Clinic, and I had my first consult at about week 4. As I said, what follows is from my perspective as the patient with the insight of my medical understanding, not necessarily my medical expertise as an oncologist, but my medical understanding of what we tend to do as healthcare providers, contrasting that to what the patient feels and sees when we're sitting there in that very vulnerable state. Next slide, please. Words are important, but our perspective as the patient is critical. As healthcare providers, and I'm sure for those in the audience that fall into this category, sorry, you'll understand what I hope you'll understand what I'm trying to describe. We train for many, many years in our respective areas of discipline. The terminology that we learn is precise and reproducible amongst ourselves. We know, or you know, exactly what you mean when you say the word, the phrase, even the sequencing of the concepts. We have trained for a long, long time to do this in a very precise way. And so when we say something to each other, we understand exactly what we mean. From the patient's perspective, we don't have any of this formal training in that particular area or discipline. And I will suggest to you that this has nothing to do with intelligence. In other words, if I brought the good Dr. Zemek into my oncology clinic for a consultation, I suspect he might be a little frazzled behind the ears as I use my oncology terms, protocols, concept, and provide him with information that he is not used to and he is not the expert in. These are unique to your areas of training and certainly, importantly, not as in ours, the patient. So for us, all this terminology is new or mostly new, but certainly the concepts that we are trying to assimilate are for the most part new. And we have to interpret all this information that you're giving us, and we have to do it by internalizing it in our own unique experiences. Finally, this is not intentional in any way, but our memory is selective as best. As Dr. Zemek portrayed that lion, we are in this hyper-aware state. This is really not optimal for bringing information in. And so we take in whatever we can, however we can. Let me provide perhaps 2 examples. The first would be from my own oncology or clinic experience as the healthcare provider. I was treating a young woman with breast cancer, and she came in one day to the clinic and thought she had a recurrence or that the breast cancer had returned. To know for sure, you have to do an image and a sample or a biopsy, and the waiting can be crazy making for both the healthcare provider, the physician, as well as the patient. I finally got the result back. I picked up the phone and I called her at home, and I simply blurted out, "It's negative." you could hear the pregnant pause. There was no response at the other end. And when she finally spoke, it was clear that she was really shaken. For her, negative meant bad. It means the cancer was back. It took a while to settle her down and to understand this. For us in the oncology world, as the healthcare providers, we knew exactly what we meant when we said negative. To us, it was a good thing. There was no evidence of cancer in the specimen. For her, it was a different story. Let me give you one other example that speaks to my own experiences. I saw the consultant in your Transcendent or Concussion 360 clinic as part of my rehabilitation. As has been suggested, the Buffalo test or the bike test was recommended to me. I heard the word bike. I put a smile on my face. I felt normal again. But for me, a bike test is what I understand a bike test to be. And not only do I do the cycling that I mentioned to you, but I'm a fairly avid racer and cyclist. And so I train all the time on the bike. And I brought my understanding to the bike test. I put on my fancy Lycra bike suit. I had my own heart rate. I had my headband, my water bottle, my clip-in pedals. I showed up ready to do a performance or physical test that would push me to my maximum to determine my training program. This is what I understood the bike test to be. The research associate that was working with me got me on the bike. She very kindly asked me, "How are your symptoms?" which, is, you might recall, were the headache and the nausea. And she recorded how bad they were. The numbers were 2 and 3. She then looked down at my heart rate and said, "Well, what's your usual resting heart rate?" And I very calmly said, "Well, don't worry about it. It's usually very, very low." And of course, it was just racing along. All I could think of is, why am I so nervous about this test? I never put 2 and 2 together. The test started. It started at an extremely low level of effort. She let me go for about 2 minutes and then asked me again, how are my symptoms? And of course, they had worsened. She recorded the numbers, moved the effort up just a little bit, and after a minute or so, cut me off. Obviously, the nausea was worse, the headache was worse, and my heart rate was just flying. I looked at her devastated. From my perspective, I had failed my bike test. I burst out crying and I was inconsolable like a little girl, not understanding what had happened. And it took a while for my husband to tell me what had actually been told to us. He remembered. I did not. Next slide, please. We know that our ability to take in this information that is being provided in the consult or in the exam room is poor at best, as I suggested. And we actually have research around this that it's estimated to be about 10%. There are many contributing factors, as you might imagine. And for the most part, I think many of you will be able to add more and understand the ones that I have highlighted. As I said, the terminology, even for us in the medical community, if we're not the content expert, this terminology, the concepts are new. We're usually quite symptomatic when we're in that clinic, either physically, emotionally, and likely both. And the content then, as I suggested, has to be interpreted or understood based on our previous foundation or experiences. And that's what we as the patients bring into the clinic setting. We also have our inherent biases or preconceived ideas. And so when we show up, we are showing up with all of this information and taking your very precise language and interpreting it in the only way we know how, based on our previous experiences and abilities. And as I said, finally, when you're scared, you are that lion. You're ready to pounce. You are not ready to learn. And so our retention of all of this is quite poor. Next slide, please. And finally, in my last few minutes, I'd like to just address something that I thought was really important: human factors, or the bottom line. In my many years of being the healthcare provider, as you can imagine, particularly in oncology, I was always asked, am I going to make it? Am I going to be okay? And while I did my best as that healthcare provider or physician to be kind, to be passionate, to be empathetic, in the back of my mind, as the scientist in the room, as the one responsible for that healthcare and that patient's care, I kind of said to myself, well, I'm not God. I can't promise them they're going to be okay. Why are they asking me that? I've talked about the statistics with them. I've given them all the numbers I can. They're looking, what are they looking for? Are they looking, I can't give them more because I can't make that promise. But there I was, that patient, as vulnerable as any patient could be. And all I wanted to know was I going to be normal again? And in fact, I realized what us as patients are really asking is for your not only empathy and kindness, but for your hope along with us that we will be okay to the best of our ability and your ability to be there with us and for us. And that's really what we're asking. Can you continue to be hopeful with us? Can you continue to be present for us? Yes, honesty and empathy are important, and you've got to speak the truth. And we need to go back to the statistics as healthcare providers because it does guide us of when to change course or when to intervene or when something is not right. But as patients, we're not asking about the statistics. We're asking for your hope and for your presence and for your empathy and kindness. And in my opinion, if you can be there in that way, then you are going to answer the question for them. So in summary, the next slide, please. These are the perspectives or my insights sitting there as the patient and reflecting back as the healthcare provider I was for many, many years. Words are important, but the patient is going to bring his or her own unique experience into that room, whether it be a consult or a follow-up. Be prepared to understand that and adjust your discourse as required. Remember that content retention is poor at best. This has nothing to do about intelligence. This has to do with the actual environment and physical distress we are in as patients. And so any aids such as writing it down, recording it, having another person in the room is critical and will only help the situation and the accuracy of the information you as the healthcare provider that you're trying to provide. Human factors are important. Statistics are great. We need them as the healthcare provider to guide us. But as the patient, what we want is your warmth, kindness, hope, and compassion. And in my opinion, the Concussion 360 team members that I met emulated, if not all of these, most of these concepts. Thank you.
Wow, Roanne, thank you so very much for sharing your experiences with us today. And these words of hope, presence, empathy, kindness, these are all things we can take to all areas of our lives, not just our clinical practices or our interactions around concussion, but certainly all of us involved in the concussion space. Let's keep those words in our mind and really put those into action. So, Roanne, thank you so very much. We greatly appreciate today's presentation, but also your voice and sharing so much with our Transcendent team. We couldn't do this without you, so thank you.
Thank you.
Okay, so we are halfway through our speakers today. We'll go to our third presenter of the day, and that is Dr. Kim Connelly. Dr. Connelly is a cardiologist and scientist at St. Michael's Hospital, Unity Health in Toronto, and a professor of medicine at the University of Toronto. He serves as the executive director of the Keenan Research Center for Biomedical Science and the head of the Division of Cardiology. His research focuses on cardiovascular imaging and the impact of diabetes on cardiac function, with a translational program aimed at improving therapies for heart disease. He is widely recognized for his contributions to cardiovascular research with an extensive publication record, significant research funding, and leadership roles in national guidelines and editorial boards. We are so grateful to have Dr. Connelly with us today, and without further ado, I will pass the virtual mic to you. Thank you, Kim.
Thank you, Nick, and thanks. Really appreciate the opportunity. Oh, have I frozen? Can you hear me okay?
We can still hear you, Kim.
Kim,
Okay.
we can hear
Yeah.
you. We can't see you, but we can hear you.
I probably forgot to pay the internet bill here at St. Michael's in Toronto, you see. So, but we'll see if we come back. I'll see if we can stop the video and start. See if that works. Okay. So yeah, thanks very much for the opportunity. So I think a lot of people ask the question, what is a cardiologist doing talking about concussion? I'm going to take folks on a little bit of a Cook's tour as to how these potentially sort of separate themes actually align incredibly well. And I just want to, acknowledge Roger. Roger has invited me to be part of the Transcendent team. Incredible work, really unbelievable work that's been done and led the way with, folks like Veronik doing the incredible exercise work. And I'm going to give a slightly different perspective about how we've been approaching this as well. But I think you'll see that the themes more converge than diverge there. And I also wanted to shout out Dr. Segal. I'm a cyclist as well and understand. I unfortunately see a number of folks now who've had a similar impact as yourself, and also send them to Concussion 360. So they've had outstanding care. So a little shout out there. So, the objective today was to really sort of go over why was I interested in this, and it starts to align about some of the fancy MRI measures that we're using to measure cerebral blood flow, and how this becomes a key node into the symptoms and signs that occur when you've had a concussion episode. And I'll give you a bit of a glimpse into how we're approaching potential ways to identify this and also to develop therapeutic strategies alongside the exercise. This is all alongside the exercise to see if we can improve outcomes of folks who have these concussion-like states. So Roger's very nicely gone over this, so I'm not going to spend a lot of time. But when I started medical school, when you had a concussion, and I'll call it phase one, the trigger, you were told, go home, turn off the lights, and certainly whatever you do, do not get on your watches, your phones. Maybe people shouldn't do that anyway, but you should really lock yourself up and let your brain heal itself. And as we started talking to these folks, whether it was friends or patients or so on, we started to see that there was a number of themes that came through with the symptoms they had, and can be extremely debilitating, as Dr. Segal has already told us. And in fact, I've got a number of folks who've had these for many, many months, and in fact, been unable to work for more than 6 months. So this can become a profoundly debilitating state. And at the same time, as a cardiologist, I often see folks whose heart rates are elevated. And I started to recognize that there was this overlap in many of the symptoms. And again, Roger really nicely went through and discussed this fight or flight response with the beautiful analogy of the lion there. And when we started to put these two together, we recognized that there was a lot of overlap between what was happening when you'd had your concussion injury and what we call autonomic dysfunction symptoms. And a busy slide, but in the middle here, you'll see where we see clear overlap between those two. And on the right, I've just outlined, because these are large words, maybe not everyone's familiar with them, but there is two components of this autonomic function. There's the parasympathetics and there's the sympathetics. And you're not meant to read this, but they really have extreme and profound impacts on the body and affect all components of the body there. So I call this is the second phase. One, you've had your injury. Two, we now starts to manifest as changes as Roger outlined. And that's when I started to realize, well, maybe I'm wrong. Maybe as a cardiologist, it's not all about the heart, that maybe another organ like the brain may in fact be extremely important. And my ego's big enough that I was able to say, okay, I better start looking into this, because we've got it wrong if we think that the heart is the heart of the problem here. There's something else driving the symptoms. And at the same time, studies using advanced imaging techniques, and this is an MRI study, started to look at what was actually happening to the brain. Now, Roger's already outlined, for most folks who have that injury, if you do a standard CT scan, a standard MRI scan, there's no structural abnormality in the brain. We don't see evidence of a stroke or bleeding into the brain or major damage to the tissue. But we know that it is absolutely affecting the symptoms, the headaches and other things, as well as this autonomic nervous system. And it actually comes back to what happens is when you have that injury is you start to modify blood flow within the brain. So normally what happens, your heart pumps, it goes through the arteries, and your brain has its own system which modifies blood flow. But in folks that have had a concussion, and what these bright colors are on this MRI scan are different areas in the brain, and we can see some areas which have really bright, that have a lot of blood flow, and other areas that are dark and have very reduced blood flow. So now we're starting to see that impact of what concussion actually has. You won't see it on a standard scan, but when you do detailed assessment, we actually see incredible changes in blood flow. So normal blood flow in the brain, somewhere around 45 mils per gram of tissue, it might even be halved. So that's how profound the changes in blood flow can be in folks who've had an injury that look otherwise well. And we know that in fact, the degree of change in blood flow correlates very well with that clinical presentation. And this is important because as a scientist, I'm always asking not what has happened, but why does this occur? Because if we understand the why, we can come up with a way to treat it. And that's the things that I'm always thinking of. And if we go back to our patients, you can see what happened early on. You're locked in a room, you've got your symptoms, you start to become deconditioned. What happens when you become deconditioned? That sympathetic and parasympathetic nervous system actually goes in the wrong direction. What does that do? It directly goes back to the brain and can modify things like cerebral blood flow, which then directly impact your symptoms, make it worse, which causes further deconditioning. So this vicious cycle, if you will, starts, and we can now see why what might be a simple innocuous injury can then result in such profound symptoms there. So you can see why this paradigm now that the Transcendent Group has really been absolutely pivotal globally in leading and getting people active again is so important, because this provides a break on the vicious cycle and can start to improve the symptoms there. But as I said, I'm always interested in, well, what actually causes the change in cerebral blood flow? How did that occur? And this is where my other area in cardiology actually became useful in starting to understand how what we were seeing in other areas of cardiology were actually very similar to what was happening in the concussion space. And here's a nice photo of our hospital. If you're ever downtown St. Mike's, this is what it looks like on Shooter and Queen Street there. So this is our neuroimaging team at St. Mike's. I work very closely with these two gentlemen here, Tom Schweitzer and Nathan Churchill, as well as other folks in the space. And we started then to get together and think, well, we now know there's a change in cerebral blood flow. What might start to modify it? So how are we addressing this to, again, further understand our knowledge in a complementary way to what the Transcendent Group is doing? And so we've taken a slightly different approach. And what we do here is, again, in the MRI scanner. So these are very detailed studies. So for most people who have an injury, this is not what you're going to get. This is for folks who've then had an injury. We're putting you in the MRI scanner and we're doing very detailed assessment. And we do things called what's called a cold pressor task, breath pacing, where we get people to breathe in and out, hand grip exercises or breath hold. And what these are designed to do, at the same time that we're doing imaging of the brain, looking at blood flow and looking at how the brain responds to that, we can start to understand what's happening to this parasympathetic nervous system and sympathetic nervous system. Again, with the endpoint of being further understanding what's occurring, with the ultimate goal of trying to identify, well, what is the major abnormality? So then instead of writing a prescription for a drug, we can further write a prescription for what might the exercise and further advice we can give to improve those symptoms. And in this little figure up here in the center of the screen, we've just purchased an MRI compatible bicycle. And where that's useful is now we can be very precise with the degree of exercise, a bit like what's done with the Buffalo test, so that we can again be more prescriptive and look at when, with a certain degree of exercise, are we starting to see changes within the brain, so we can look at that and then come back and actually give much more detailed information. These studies are just starting now. We've just purchased the bike, so we haven't actually put anyone through that. But at the moment, we do these other investigations. So you can see this is very complementary to the detailed program that the Transcendent group is giving. And we, again, hope this will further help our understanding of the disease process. Now, the second thing we are working on, and this comes back to the question of why is cerebral blood flow modified? Now, this is a complicated slide. I'm going to simplify it for you. Basically, we have arteries in the brain that allow the blood to go through to the brain. These arteries will respond to pressure. And this is a very old phenomenon called the Baylis or myogenic response. What it basically says is, if the heart pumps harder, those blood vessels receive more blood, they will actually start to squeeze down so that the brain gets the right amount of blood. And if the blood pressure falls, they will open up to get the brain the right amount of blood. But, and this is a big but, when you have an impact like concussion, this response becomes quite abnormal. So instead of these blood vessels in the brain improving blood flow, they in fact have the opposite effect and reduce blood flow there. So this now provides that link between how the injury then has a direct impact on the brain. And I'm not going to go into the details, but it's probably through the process of inflammation. This is a big buzzword at the moment, but just so happens that the main driver of what screws up this response is inflammation there. And in detailed studies, which no one needs to go into, we've mapped out exactly how this occurs. And why this is important, now we know how it occurs, we've been able to go back into the lab and develop a drug which can reverse this impact. Now, at the same time that was occurring, I'm going to tell you what happened, not in the concussion space, but in folks who have heart failure, where their hearts start to fail, or have a terrible condition called a subarachnoid hemorrhage, where an artery in the brain bursts and their brains all of a sudden are full of blood and increased pressure. As it turns out, when those two things occur, there is inflammation. Inflammation affects how those blood vessels respond, and we see a dramatic reduction in blood flow to the brain. Standard folks with heart failure have on average a 50% reduction in blood flow to the brain. Not surprising then, we see impacts in cognitive function. You can't think properly if the brain is not getting blood flow. And we see the same thing when people have these blood vessels that burst into the brain. And in studies so far, we've been able to show with our new drug that we can basically completely reverse these changes in animal models. And what we've done now is working with the FDA, which is the US regulatory body, the EMA and Health Canada. We've now been fast-tracked to study the impact in persons with heart failure. We're then going to be doing a second subarachnoid hemorrhage trial, and if they work, we'll actually be then starting, and we're trying to get funding to look at this therapy in folks who have concussion. The mechanisms actually align very nicely. So as I said at the beginning, it looks as though they're separate. They start to come together here, and this is just our team that has been working on the study. And we hope to start this next week. And this is a Canadian-led study. So hopefully we're going to have very positive news and move this forward. And this is just an example of the clinical trial. You'll see there's similarities here. Roger outlined in folks that have concussion, they have advanced MRI scans, wearables, blood biomarkers. We're in fact doing a very similar protocol, but this will initially focus on folks who have heart failure. Again, more similar than dissimilar, although on the surface you would not expect that that's the case. The third thing that we're very interested in is wearables. I think we all recognize the value of wearable tech. Having your Apple Watch, which Garmin watch, whatever, provides a lot of information. We've done a lot of studies on these looking in our athlete population showing that they're pretty good, but they're not yet ready for prime time. They need to be, some of the algorithms need to be tweaked a little bit more. So in fact, we've formed a company. Here's Paul Doran at the bottom, who's one of our world leaders in autonomic dysfunction as it relates to cardiac arrhythmias. And we've now developed a new algorithm, and we're actually testing this on our folks who are in our concussion study with the hope then that we'll be able to come up with a watch with high fidelity data that we can again use to then further optimize that exercise prescription that you might get from the concussion group who says, go out and do this. We can again get that data and start to nuance that again with the hope of more rapidly improving recovery. And again, this is a Canadian thing. The company is a Canadian-based company. So really trying to keep it all here and make certain that we can improve the outcomes. And in fact, this will have hopefully much larger impacts, not only in the concussion space, but of all folks who have respiratory disease and other cardiac conditions there. So this is a bit of a snapshot of our program. You can see starting off as a simple cardiologist, not recognizing how many of these things overlap. But at the moment, we're still in this education phase so that folks start to recognize what the symptoms are and getting them through to the right folks who can actually start to then give those exercise prescription. Detailed autonomic testing is going to be absolutely crucial as we start to nuance and tease out exactly what's going on. Wearables are a key component of that. And I hope that one day I get invited back to speak here again and we'll start to then talk about where we are with our therapeutic strategies. We're a long way off, so I don't want to overplay it at the moment. We're at the early phase, but you can see by putting all these pieces together, 10 years ago, you were locked in a dark room. Now we actually have an unbelievable array of things that we can offer our patients with the hope of getting you back doing what you love quickly. And with that, I'll stop and thank Nick for the kind intro.
Dr. Connelly, thank you so very much. I'm left fascinated. As someone who's been involved in the concussion space for many years, you've really got my brain buzzing. So thank you. That was incredible. This overlap and what your team is planning to uncover around the overlap is commendable, and we're cheering you on. So thank you for sharing your work with us today, and certainly we will have you back once you've uncovered some of these unknowns along the way. So thank you very much, Dr. Connelly. We will now end our session with our final speaker, Dr. Veronik Sicard. Dr. Veronik Sicard completed her PhD in exercise science and her postdoctoral fellowships in neuroimaging, concussion, and exercise. Today is actually Veronik's last day as a postdoctoral fellow at the Children's Hospital of Eastern Ontario, and she'll be joining the University of Laval as a research professional. So huge congratulations to Veronik, and we're thrilled to have her share her work with us today. Veronik, thank you for being here. Thank you for all the work you've done in the Transcendent program, and will continue to do in this space. And I will pass the virtual mic to you.
Thank you. So today I want to talk about something that happens after a concussion that most people, including several clinicians, don't recognize. It involves your body's ability to regulate itself after doing something as simple as standing up. By the end of the talk, I want you to walk away with answers to 3 specific questions. Have you ever stood up too quickly and felt dizzy, like the room tilted for a second, or maybe your vision went blurry, you felt your heart race? Well, for most people, that passes in seconds. We stand up dozens of times a day without even thinking about it. But standing up is actually a complex physiological challenge. After a concussion, the system responsible for handling that challenge can break down, and what is usually automatic becomes difficult. So here's what's going on inside your body. When you stand up, gravity pulls your blood towards your leg, and your brain has to quickly tell your heart to start pumping faster and your blood vessels to tighten up while keeping a steady blood pressure. All that to keep the blood flowing to your brain. In a healthy system, this happens in milliseconds. After a concussion, however, that signal can fail. Blood does not return to the brain fast enough, so the heart rate starts beating faster and faster to return to a normal state, and you might start feeling symptoms like dizziness, brain fog, nausea, blurry vision, and this is what we will call today orthostatic autonomic dysfunction. I will probably say AD a lot because autonomic dysregulation or dysfunction is a long word. Now, how do we assess orthostatic functioning? One of the protocol is what we call the active standing test. We ask the patient to lie down on a table for at least 2 minutes. We will take different measures, such as the blood pressure and the heart rate, and we will also ask a list of symptoms. And when they stand up again, we will measure all of these things again. As I explained a minute ago, in a healthy system, we are expecting a small increase in a heart rate. But as I said, it's not that intense, maybe 10 to 15 to 25 beats per minute, depending on age. And we expect blood pressure to pretty much stay stable. If these heart rate and blood pressure responses exceed the established thresholds, the ones that I'm showing here on the right, we classify that as a physiological autonomic dysregulation. At the same time, we capture the patient's subjective experience. We'll ask them whether they have symptoms such as confusion, dizziness, lightheadedness, weakness after standing up. And if these symptoms appear or worsen, we'll call that symptom provocation. Other groups also call it orthostatic intolerance. Before I tell you what we found, here's where the field stood when we first started. Studies on orthostatic autonomic dysfunction after concussion existed, but in a very small quantity. Reported prevalence for the physiological signs went from 3 to 73%. That's a huge spread. It suggests inconsistent methodology across the different studies. And for symptom provocation, it was between 37 to 47%. And importantly, all of these studies were in adolescents. So here are the 3 questions we set out to answer today. First, how common is a autonomic dysregulation after concussion? Second, what does it look like? Is it more of a heart rate problem, a blood pressure problem, or a symptom problem, or a little bit of everything? And then we also wanted to answer who tends to have it. Are there factors that we can identify? So our first major study looked at autonomic functioning in children and adolescents. This study is published, and if you want to see it, feel free to scan the QR code. This study represents the largest study to date examining autonomic dysregulation after a concussion. We used clinical data that was collected during routine orthostatic testing at the 360 Concussion Care Clinic. There were 764 children aged 5 to 18 that were eligible, and they presented within 45 days of a concussion to the clinic. Of those, 451 had complete orthostatic vitals data. Usually, before seeing their doctor, every patient will complete this active standing test just as part of the routine care. Here's what we found. About 1 in 10 children and adolescents, so roughly 10%, showed physiological autonomic dysregulation, meaning that their heart rate or blood pressure responded abnormally when they stood up. It was most common in boys aged 12 to 17. For symptom provocation, 1 in 4 reported new or worsening symptoms upon standing, and that was more common in girls than in boys. Now, when we look more closely at the pattern, the most common sign was an increase in heart rate alone, and it was followed by an increase of decrease in systolic blood pressure alone, and very few participants met multiple criteria at once. This matters for clinical practice because if you're only checking blood pressure, well, you might be missing a lot of cases. Similarly, if you are only checking the heart rate, you may be missing a lot of cases. And here's a finding that really surprised us. We assumed that physiological autonomic dysregulation and symptom provocation were just two sides of the same coin. That if a patient reported symptoms, they'd likely show the physiological signs too. But that's not what our data showed. If we take only those with either the physiological signs or the symptom provocation, so here on my image, the colored icons, then we find this pattern where most patients had either physiological signs of autonomic dysregulation or symptom provocation, but not both. Only 1 in 10 had both conditions. It suggests that it might measure something different and that both subjective and objective measures are needed for a complete clinical picture. Then, who are the children at highest risk, or which variables are associated with autonomic dysregulation and symptom provocation? Well, for the physiological side, we found that neurodevelopmental disorders like ADHD and learning disabilities were associated with physical AD. For symptom provocation, the picture was different. We had both pre-injury, peri-injury, and post-injury characteristics that were associated with those symptom provocation, including female sex, a pre-injury mental health diagnosis like depression or anxiety, also post-traumatic amnesia, so the difficulty to remember what happened either before, during, or after the concussive impact, and the current concussion symptom burden on the day of the testing. As you can see, these profiles don't overlap perfectly, which again supports the idea that we're dealing with two related but distinct phenomena. Following this pilot project, we developed a research component for Transcendent to really dig in deeper into orthostatic autonomic dysfunction in our concussion population. Here's the protocol that Dr. Zemek showed you earlier, and I want to bring your attention to the two parts outlined in red. So first is the initial visit where we ask patients whether they are interested in being part of our protocol and we get consent. We'll also collect basic information on them and their medical history and the details of their concussion. And then they will complete our orthostatic protocol. So here for Transcendent, instead of a simple standing test, we use a tilt table. It is a table like the one you see in your physician's office, but it has a motor, and it will bring the patient from lying flat to 70 degrees in about 15 seconds. It's similar to a roller coaster, in my opinion. This test is considered the gold standard for assessing orthostatic function. Similar to the previous study, we took measurements of heart rate, blood pressure, and symptom in the lying position and also after standing, but this time, not just at one time point after standing, but we did it repeatedly over 3 minutes. We looked at immediately following tilt and then 1 minute intervals for up to 3 minutes. And our second study was submitted as of yesterday, focused exclusively on adults. We included 597 participants age 18 and up in this study. They presented to the concussion clinic within 3 months of their injury from July 2022 and October 2025. They were a median of 20 days post-injury, median age 34 years, and the majority female. What we observed is that 1 in 6 showed physiological signs of autonomic dysregulation, and 3 in 5 had symptom provocation. This is roughly double what we saw in children using the active standing test. Now, if we break it down by age, we see that younger adults aged 18 to 29 had the highest rates of physiological autonomic dysregulation. For symptom provocation, older adults over 60 years showed lower rates. However, it's important to note that this age group was very small with only 34 participants, so we should interpret that result cautiously. Again, when we look at the pattern, we notice that an isolated increase in heart rate was the most common, with more than 65% now in adults. Isolated drop in the systolic blood pressure came second, and very few participants met more than one criterion. Here's where our tilt table design really paid off. When we look at how many people met the threshold for physiological autonomic dysregulation at each minute after tilting, that's the graph on the left, you see that the number keeps going up. In other words, the longer patients stand, the more cases we detect. The same trend holds for symptom provocation on the right on this slide. And it suggests that a single measurement after standing underestimates the true prevalence of autonomic dysregulation. In a subset of 297 participants who completed the full 3-minute protocol, we see that physiological AD continued to increase at the 3-minute mark. However, this does not hold for symptom provocation. We see somewhat of a plateau between 2 to 3 minutes. These results have real implications because current clinical protocols used in concussion assessment is often at 1 minute post-standing. Our data suggests that it might not be enough. We need to keep our patients upright for longer, but how long? Well, we're not sure because we did not see a plateau here in our study, but for other population like POTS, they use 10 minutes. Once again, here the overlap between patients with physiological AD and symptom provocation was low in about 22% of them. So most fell into one category, but not both. Risk factors were younger age for physiological AD. And for symptom provocation, we saw associations with female sex, pre-injury mental health diagnosis, a history of migraine, confusion and answering slowly at the time of injury, and a current symptom burden. So this is overall consistent with the pediatric sample we saw. So we saw the prevalence in adults was higher than in children and adolescents. But in our first study, we used the active standing test and the other, the tilt table. What if we use the tilt table in children and adolescents? Here I'm showing early data from the Transcendent Youth Cohort. We have 122 participants aged 10 to 21 with a median age of 15 years and a median of 12 days post-injury. Using that tilt table, we found 1 in 4 showed physiological AD and 1 in 2 showed symptom provocation. Symptom provocation was more prevalent in girls than in boys, and these numbers are preliminary. We are still recruiting participants, but overall, it shows that it's consistent with the adult findings, and it might suggest that the tilt table detects more cases than the simple standing test. So let me bring you back to the first questions and we'll answer them. So first, how common is autonomic dysregulation after concussion? Well, the literature gave us a wide range. Our data narrows that considerably. In children using the active standing test, it was 10% physiological and 23% symptom. In youth and adults using the tilt table, those numbers were approximately double with 23% and 58%. So what we have to remember here is that AD and symptom provocation are common after a concussion. Now, what does it look like? The most common sign was an isolated increase in heart rate, and it continued to increase up to 3 minutes after standing. Physiological signs and symptoms are largely independent. Most patients fell into one or the other category, but not in both. And this has important clinical implications. So we really need both objective measurements and patient-reported symptoms to get the full picture. Now, who tends to have it? Physiological AD was overall associated with younger age, and symptom provocation was associated with female sex, pre-injury mental health diagnoses, and overall higher symptom burden on the day of testing. These might be identifiable risk factors that can guide screening and monitoring in clinical practice. And future research will help us refine these potential risk factors. Just quickly, we're not done yet. We still have a lot of questions that we want to ask, and this is already in motion. So we want to know, does exercise help people recover from autonomic dysregulation? We already saw earlier in the other talks that yes, we think it does help. So we want to test that and have evidence-based recommendations. Then is orthostatic intolerance linked to having trouble doing physical activity or exercise, like even a brisk walk? So we want to know if those two are part of the same problem or are they using different pathways? Moreover, we want to know what is happening in the brain. So we already talked about cerebral perfusion. It's also something that we want to answer in Transcendent, because what's interesting in blood flow is that it's closely linked to the autonomic nervous system. So if that system is not working properly, well, it could affect how the brain is being supplied with blood, especially during challenges like standing up or physical activity. And at the same time, we know exercise can increase blood flow to the brain, and it may help restore some of that dysregulation over time. Lastly, we want to know what features of autonomic function can predict recovery. In our protocol, we're also measuring how the heart responds to the physiological demand of standing up using a chest strap that tracks the heartbeats hundreds of times per second. And this tells us how well the body adapts to everyday stressors. So we will be looking into that in the following weeks and months. And this work truly reflects a collective effort. We are incredibly grateful to our international collaborators, our dedicated day-to-day staff at the clinic, our data team, our advisory team, and our funders for making this research possible. And most of all, we really thank all of our research participants, without whom none of this would be possible. And I want to thank especially the team that I've been working with for the past few years. It was amazing, and I hope I'll be invited to speak more about our future research aims in next sessions. Thank you.
Thank you, Veronik. Fantastic. And thank you for sharing this hot off the press research. Certainly exploring things that others have not and aren't. And we're so grateful that you're diving into that topic and answering some of these important questions. So thank you. Just a collective round of applause, virtual round of applause for our 4 speakers today. We are so grateful for you sharing your insights with us. We will now take some time to ask and answer some questions. So we'll spend the remaining 15 minutes together having some discussion. I'll invite you all to use the Q&A function on your Zoom screen to share any questions that you might have. We will do our very best to get to as many questions as we can today. But if we don't get to them all, please reach out to us at Transcendent, and happy to facilitate some answers where we can. So first up, and thank you for those questions that have been shared both in our registration phase of the program, but also on our Q&A function. And I think just coming off of your presentation, Veronik, there have been a few questions related to postural orthostatic tachycardia syndrome, or POTS, and sort of this idea of suggestions for recommendations around managing this condition in relation to concussion or just generally? And also in situations where exercise may be a challenge for people. So what might some approaches be? So Veronique, I'll turn it to you if you have any ideas on this, but also others, please feel free to chime in.
Right. I will let the physicians in the room answer for treatments. I think they are better equipped than me. I study physiology. The big difference between what we see in concussion and the postural orthostatic tachycardia syndrome is that POTS is a chronic condition, so it lasts longer. And also, there's no drop in blood pressure during POTS, which is one of the criteria to have it. So here we're looking at right after a concussion, do people have um, a response that is similar to POTS, but they don't qualify yet for POTS. However, we also know that concussion is the second most prevalent trigger for POTS in children and adolescents. So this is the difference between what we're looking at and what is POTS, but there's a link between the two. But I'll let the two physicians in the room speak of
Perfect.
treatment
Thank you.
or rehab.
Thank you, Veronique. And Dr. Connelly, I know this is a big part of your program. Any thoughts related to POTS today?
Yeah. So POTS, as you alluded to, postural orthostatic tachycardic syndrome represents one of these autonomic dysfunction syndromes that really is a continuum. At one end, you can have the blood pressure changes. At the other end, we have the heart rate changes that occur with changes in posture there. And there are very formal criteria. Now, a lot of the data that came out of this, actually, interestingly, as an aside, came from astronauts. So when you go to space, and there's no gravity, well, all the things that tell your blood pressure and heart rate to improve get screwed up. So when you come to Earth and all of a sudden there's gravity again, your blood pressure falls and your heart rate goes up. And what we recognized then was the way to address this was you need to keep the pipes in the body full of fluid. So what does that actually mean? Salt. So what does salt do? When you ingest salt, it gets into the bloodstream and it pulls water into it. So there's a number of specific criteria for POTS. We won't go into those, but one of the key defining features is the tank has to be full. And what do I mean by that? We recommend high doses of salt. And what that does, that with water will get the salt into the blood vessels. It will expand those blood vessels so that when you do change your posture, we start to lower the impact on the heart rate and in some of these overlap syndromes, the blood pressure there. And often what you then need to do is get people to exercise lying down where we take gravity out of the equation. And in some instances, we actually have to use pharmacological treatments. There's a drug called propranolol, which is an agent known as a beta blocker, or another drug called ivabradine, which is this IF channel blocker. And sometimes other drugs like compression stockings or other drugs that also increase the fluid within the system. What we're trying to do is stop that change when you go from one position to another. It can be a difficult treatment. It can take a long time. And usually what I tell people is as long as you have been suffering those symptoms is as long as it will take me working with you to actually revert. Folks often don't mind because I often say things that you weren't supposed to eat before, like salty chips and salty peanuts. You can have them in a small degree, right? You got to watch the weight impacts, but this is actually the absolute key treatment for POTS. And as Veronique beautifully alluded to, we know that if you've had concussion, it often triggers this response, and one of the manifestations may be that. It's not a simple thing to treat, though. It takes a lot of time. And I think back to what Dr. Segal said, this is where the physician really does have to go through this very careful because it's very frustrating. And POTS has all those same symptoms, the brain fog, the memory disturbance, the insomnias, the other things. These are a major component of this syndrome. So it's not just your heart rate changing, it all goes together. So, I mean, Roger, obviously, you see this all the time in the Emerge. I'd love to hear your thoughts.
Yeah, I think you covered it really well, Kim. I'll just add two little quick things. First, one of the beauties of being a pediatrician is we don't have to worry about their heart failure and risk of stroke, so we can tell them to make as much salt as they want. So I let them have pickles, and a lot of it's extra fluid as well. So pickles is another great healthy alternative to the chips. The other thing is, I really tell my patients, this is not, you're not stuck at this. Each day you're going to tailor it for you, and that's really the goal of this is precision care. And what works for person one may be tweaked for person two. Some people may have different recovery curves, and that's where that close monitoring, close follow-up is so important on how they're doing. So I think those would be the two take home for the salt and the recovery. Second thing I also want to add is the precision also ties into the person. You know, if a person's a hockey player and wants to get back to eventually competing in hockey, well, a medicine that works for a 65-year-old may not work for a 17-year-old athlete. That propanol may be the exact opposite one for them because they feel like they can't exercise well with that. So I think that's where the precision care and tailored for the right treatment, the right person, that's our challenges in this field is to keep moving that forward and figuring out what's the exact right thing for each person and their needs. Going back to that North Star, what are your goals as a person, and what do you need to get back to doing the things you love?
Fantastic. Thank you, Roger, Veronique, Kim. Great discussion there. Roanne, I want to switch gears a little bit here. And you were so gracious in sharing your lived experience with your concussion experience and did share a little bit around exercise and getting on the bike and what that meant to you. A question that did come through was around this idea of gradual exercise or pacing and that playing a role in your recovery. Would you mind diving in a little further into that? What was that experience like for you? And perhaps some insights for the audience today.
Um, Happy to. So, having said that, I think important to know that I do train all the time. So I will train right through the winter on an indoor trainer. And so the setup was already there for me, and I understood the platform. So in that respect, it was relatively easy for me to implement the recommendations that came from the clinic. What was frustrating for someone like me is I'm going to use the word to hold back.
Mm, mm.
All right. So again, I had to make an effort that was considerably less than I'm used to making. I'm gonna, Roger, you were, I think this is payback for my comment to you about bringing you to my oncology clinic. You called 65 old. Some of us are over 70 and still think we're athletes. So, so, to that point, um, I found the bike protocol or their Buffalo protocol very helpful for me. It was something I recognized, something that was easy for me to implement, and something I understood. And it not only provided a very structural way to progress myself, but I'm going to return to it provided me hope because it was something normal for me. Um, and so very valuable.
That's fantastic, Roanne, and thank you for sharing that. And yeah, I think going back to Roger's points around, really that precision treatment, right? Thinking about what is important to you as the patient and as a clinician, creating that time and space to explore that. Let's bring each other's expertise to the table and explore what the right fit is for you. So, Roanne, that's fantastic. Roger, yes, please add.
I love how this all comes full circle. I know Veronik finished her talk with talking about that bike test. We're still analyzing the final results, but I presented this preliminary results at the University of Ottawa Heart Institute, actually, of our study in which we compared and matched people who were willing to do the bike test. People like yourself, Roanne, who said, "Yeah, I'm willing to do that test," and match them to people who just for whatever reason, no, I'm not interested in doing that. And when we looked at the outcomes, the simple task of doing that test was astronomical in the outcomes. And I don't want to go into the numbers because it's still, we're still finalizing it. It has to be peer reviewed. But I was really impressed more than my wildest dreams on how beneficial that one test alone did. And I think a lot of it, when we talked about it with our world expert team, one of our team experts is a neuropsychologist, Keith Yates, and he said, of course, it's psychological too. And I think it gave you that hope. It showed you the confidence. It got you back to your life. And in addition to maybe working on the physiology, there, I think, is a really big psychological benefit for giving people hope and showing them the stepwise as well. So I think it's a really I'm excited to do a future Transcendent community talk on that when we're final with it. But I just wanted to give a little teaser for our audience that it does all come full circle.
If I could just make one other comment, there's no question there was a hope there, but you were able, your protocol allows you to be prescriptive on the effort to try and keep your symptoms under control. And maybe it's the training in me, but the numbers were very helpful for as I went from the indoor trainer to the outdoor trainer, right? I just took my Wahoo with me and I could follow all, and I have power pedals the whole 9 yards. So my setup facilitated this. I guess that would be the question back to the clinic as you develop it. How can you facilitate it for somebody who doesn't routinely do this kind of training? Because to have those numbers, I can tell you, were also very helpful to me, right? I knew how to, it was very easy, not easy. It was hell coming back, but having the numbers made it easier for me to progress.
Fantastic. Okay, in our 3 minutes remaining, I'm just going to pause and direct folks to the chat. We do love feedback within our Transcendent program. So there is a link in the chat to solicit some of that feedback. So if you're willing, please click on that link and give us an idea of how we did today and how we can improve for future community talks. We're going to close off with a question to anyone on the screen here, and that is around excitement in this field. We have lots of questions to continue to answer. There's lots to be done. But to anyone who's willing to share some final words, what excites you most about exploring this connection between the brain and the heart when it comes to concussion or otherwise?
Sorry, Nick, brain and the heart, right? So, well, look, as I tried to allude to, I think we recognize that the key mediator of all these responses is, in fact, the brain. And the heart is a pump that responds to that. So the brain is the key mediator, and the heart is responding to that as it should, as a pump with these blood pressure responses, with the heart rate related responses. But, as much as I think the heart is at the heart of the problem, I have to say the brain is what's driving these responses here. And I think I remember hearing a stat once: the number of permutations and combinations of neuronal interactions in the brain is the equivalent of the number of known atoms in the universe. So the brain is unbelievably complicated. We're going to be studying this for the next 20 to 30 years, and we've scratched the surface. But I think you can see where we've come in 10 years is unbelievable. And I think that, to me, is the key thing. There is a lot of hope now for folks that really struggle with this before, where there was not great advice, to be honest. And I think from my perspective, it's getting the broader community to recognize that we actually have specialist clinics, that we can get people in, that we can actually start to make a difference. We've still got a lot of research to go, but in this way, we are changing that needle and improving the outcomes of Canadians and hopefully everyone else in the world. So I, as a cardiologist, I concede the brain probably wins. Okay.
Okay. Well, Kim, Roger, Veronik, Roanne, thank you for scratching the surface with us today. I know there's a lot to continue to explore, but a lot to be excited about. And we appreciate the work that you do and for sharing it with us. And yeah, we look forward to more and having more opportunities to discuss this topic. I also want to thank everyone for taking the time today to be a part of today's session. Please come back, keep an eye out for all things Transcendent Concussion Program, and we can't wait to engage with you again. Without any more discussion, we will close today's session and let you all get back to your busy lives. Thank you for joining, and we'll see you again.
Thank you.
Thanks for being a great host, Nick.